Thanks, Corey. So our second talk is going to be Martin Dawes, who's head of family practice at UBC. Martin's going to talk about a project about introducing personalized medicine into family practice. And I'll let him decide if he wants to tell us how long it took to put it together.
I started at the age of 17. Thanks very much, Gabe. Thanks again for the invitation to be here. It's a real privilege. I should just say that all of this is embargoed, so please forget what I say the minute I finish. The innovations in making it work, of course that's not true, but we have spent a lot of time trying to work out how to put the genomics into practice. And I'm going to walk you through that in less than 10 minutes. That's the takeaway slide. As I say, please forget it. No, you can remember that one. I think that's non-specific. But in primary care, genetic information will make prescribing safer, more effective, and it's going to save a ton of money. You can see that Corey and I sort of build on each other's work because one is using a pharmacist. In fact, we should be using pharmacists as well as primary care. And there's a lot of dovetailing about how we discover and overcome all the little hurdles there will be in creating this. That's the bottom line to the project, is to develop and test a decision support tool, TreatGX, which creates a drug dose recommendation. So it's computerized recommendation of therapy. That's going to change the world. And it's going to use SNP data, another major change to the world, and the information in the family physician's or the pharmacist's electronic medical record, or it can be entered directly by the patient. So you can see there are several revolutionary components here. We're going to pilot test this 250 patients in the summer of this year. So we're going to announce and go live probably at the time of the PMI Summit on the 7th of June. Just stepping back a little bit, what's a family physician? Because some people get an impression of a family physician from their 2-minute consultation about a throat problem or something else. So let's just see. Assuming you had 2,000 patients, which isn't the case now, but a lot of this data relates from that time, you would be looking after patients who had any one of 450 conditions. That is the scope of practice in primary care. You would be making 2,500 diagnoses a year as a full-time family physician. That is our bread and butter. Whether it is very rare diseases or very common diseases, this is what we do. In addition, we will do 20,000 prescriptions covering 833 different drugs because we have to treat all those 450 conditions. And we will initiate that. It's not that the specialist initiates the prescription, we repeat it. We actually initiate those prescriptions. And they provide 85% of healthcare and keep people out of hospital. And without the diagnostic part, you could say the same of pharmacists, because we keep people away from the dangerous places called hospitals. Add to that genetics, and you can see we've got a bit of a problem. Already the scope is pretty large, but we've got somehow to introduce genetics into this process. So the specific problems right now, the escalation in the drug bill that's driving the Ministry of Health absolutely crazy, is that a lot of us have multiple diseases. Talk to people over the age of 60 and they'll have 2, 3, 4. Actually, these may not be diseases. They may be raised blood pressure, they may be raised lipids, so they might not feel ill at all, but are more at risk. And they'll be using prescriptions, a lot of them. Polypharmacy is now one of the problems we face. Unfortunately, the more pills you take, the more harm is done. And so adverse drug events are now the 4th leading cause of death in the United States. 20,000 Canadians will die of an adverse drug event this year. This isn't because we're careless, it's because it's difficult. The net deriving benefit from drugs is tiny. So for treatment of mild to moderate hypertension, I might need to treat 120 people for 5 years for one to actually prevent one person having a heart attack. It's a bit worrying. So, here's my decision-making time in primary care. I've done a 9-minute consultation. I've diagnosed that you've got an acute exacerbation of your chronic obstructive pulmonary disease, and that is probably infective in origin. I've listened to your chest, I've got your history, I might have done a peak flow or other respiratory test. Now, I have got to somehow incorporate a decision about therapy that looks at your laboratory results. I've got to take into account your renal function and your liver function, biophysical results, how frail are you, your wishes, what do you actually want to achieve with this therapy. I've got to look at your current medications, your age, your gender, the harm of the interventions. If I give you something, how much is it going to harm you? If I give you steroids, how much likelihood is there that you'll get a candidal infection? The effect of the interventions. If I give you something, is it actually going to work for you? The potential harms, desired outcomes, and the potential interventions, because I might have, if I start with an acute exacerbation of chronic obstructive pulmonary disease, about 20 medications I could select to give you. The less time, the bottom line there, the less time in the consultation, the more likely a prescription is given. That's a very nasty inverse relationship. 2 minutes, I'll give you a prescription. 10 minutes, I might talk to you. Very worrying. The less time in a consultation, the more inappropriate the prescription. So you can see, as we compress down the consultation time, the number of inappropriate prescriptions goes through the roof. In Ireland, primary care, treatments people over 70, 70% of prescriptions were inappropriate. Reduce that because some of it is maximum dose for too long of things like proton pump inhibitors. But in reality, it's somewhere about a third of prescriptions are inappropriate. It's not because people are trying to do a bad job. Even if they're appropriate, you go to Scotland, 4% of them have got errors in them. And that's because this is difficult. It is really, really hard. That is the decision-making tool we have. This is a simple problem, gout. It's RX files, one of the best systems in Canada and probably across the world for giving information of how to treat. There are only about 8 drugs. And that is what I have to use in my day-to-day practice to determine whether it's safe or effective to give this treatment to this patient with acute gout. We have to automate this. And genetics actually gives us the lever to say, enough of this. Let's move to computerized decision support. The genetics part of it is reflecting on those huge numbers needed to treat. One size does not fit all. If we could reduce the ineffectiveness by 10 or 15%, we would actually reduce that drug bill by a massive amount. So we take the genetics and we try and put that into practice. So genomic information, I'm just doing treatment here because obviously it does do diagnostics and prognostics, but that's next year. It needs a clinical platform. We try to put the genetics into normal decision-making processes, and people are starting to do that with depression and hyperlipidemia and so on across the world. It really doesn't work in my practice. I need something that just makes it simple. In fact, the software we're producing is so boring, I'm not going to present it, because what you do is you put in the data and it says metformin. And that's it. It actually was taken into account all the steps, 2 minutes, thank you, and says, this is the drug. So it's a really boring piece of software, but it's what I want in my practice because it doesn't just say metformin. It gives me a list of recommendations. If I click on it, then it will tell me which and why, and it gives me doses. And if I add another drug that interferes with that, it will tell me that it's interfering and give me another recommendation. So it's smart, and it's just using all the rules that are out there. That's the clinical algorithms that we're creating using the highest levels of evidence. So we go back to the guidelines around the world, bring them together, 300 hours for each algorithm, each disease, and then we incorporate the genomic information to come up with a recommendation. So this is just TreatGX in a summary. So here's the algorithm formation. A group of young doctors, 4 of them at the moment, pharmacists working together to crunch this down, sharing it with family physicians, getting feedback, applying it to cases, and saying, okay, does this work? A multiple SNP panel analysis, still in progress, being developed. We translate that into HL7 coded data, goes into the electronic medical record, results in a treatment recommendation. We use life technologies, Quant Studio, and outcomes of new graphical user interface. We are putting a huge number of pieces together. TELUS Health is our partner because they look after 10 million Canadians. and that reaches the maximum number of Canadians using one platform. Those are our other partners. We couldn't do this without a huge amount of help from a load of people. And we hope to see our first patient go through this program before the 7th of June. Thank you very much.